cloud. Okay, so thank you guys for joining in. So quick overview on what is, obviously, Catherine, you've joined in a couple of the coffee chats before. So change that over to there. There you go. See my presentation. Can you see that okay? Yeah, good. Right, so what we've done is we've decided to have a bit of a change around and kind of make it a little bit more, I don't want to call it education because I don't want to, it makes me sound like I'm educating people and I'm really not. So what we kind of decided on was having monthly topics more centered around clinical reasoning stuff. So from the survey that went out, people wanted stuff around treatment techniques and stuff, but I didn't really want to kind of make it all about this is how you massage this is how you do that. So the first one, this one, is going to be kind of, it's going to lead into the other ones. So it's going to be around clinical practice, clinical reasoning. These are going to be used for the actual CPD. They're also aimed at being lectures, discussions rather than a lecture. So I want to kind of go through this presentation-y bit. Welcome, Anne. So I'm just muting everybody so it doesn't switch between. I want it to be a discussion because that's the whole idea behind it. I want to learn things from you guys as well. The initial sessions that we're doing are centered around basic principles of assessment and rehab. And these will form a basis going forward when we go into the more specifics of kind of joint specific, limb specific, injury specific stuff. So we'll use those principles going forward on the following chats. So 2 seconds because everything has decided to stop working again. Here we go. So today's session is going to be introduction to assessment. It's going to be very kind of, I'm not going into every detail. We're going to have a quick chat about subjective assessment, what you do with that and how to form an objective plan, your objective and physical assessment, quick overview, very quick overview again of neurological assessment, how to summarize your findings, and then how to use clinical reasoning for your treatment plan. So straight in off the bat. So had this conversation on previous coffee chats, and there's a lot of different kind of theories or kind of models of how people prefer to use this. So first question I want to ask you guys for later in the discussion is, how much time do you set aside for your initial consultation? Some people do 20 minutes, some people do 30 minutes, some people do an hour. We've had people who do 2 hours. My kind of thought process on an initial consultation, if it's the first time you've ever met that person, you don't get a second chance to make a first impression. And this is your first chance to make a genuine, good first impression with somebody. Mute you there. This is the first impressions. You don't get a second chance to make a first impression. And that can give you such a good opportunity to kind of make a good clinical alliance with this person, get them to buy into what you want to do. Okay, so this is kind of a few things I've picked up along the way, kind of from kind of experience and just kind of chatting to other people really. For the people that have just joined as well, if you're struggling to see the presentation, go to the top right and click on speaker view, and then it will bring me up full screen. So first thing I do after we've done like the consent form, the screening, all that kind of stuff, I want to kind of, whatever they've told me previously, I'd take no notice of that for this next bit. And I kind of go, right, just tell me why you're here. And I literally just sit back and let them just talk at me, really. And I don't touch my computer. I don't do anything. I literally just sit and listen. And that's the important bit. Listen to what they say. And I've said this to like other therapists before, it sounds obvious, but how much do you actually take in from that actual conversation? How much are you actually listening? If I, so it might be like one tiny little bit, but it could be so important. And you need to listen to their story in order to kind of get to know them a little bit more, especially if it's the first time you've ever met them. Are your questions relevant? Seen this before when I was at uni. I've seen it with like placement students who've come to me, right, how are you going to approach this? And I go, I'm going to ask this, I'm going to ask this. It's like, why are you going to ask that? You don't know how to deal with the answer to that question, and you don't know how to take that forward. Don't ask it, because there's no point to doing it. Try to avoid putting words in patients' mouths. There's certain things I try not to use, and it also links into the next point, avoiding negative language. I don't use the word pain with people until, if they say pain to me, I might start to use it because that's their descriptor. But I try not to use it because I find it quite negative. I tend to just kind of call it, tell me about your symptoms, tell me about what's wrong, your complaint. I try not to use the word pain, because to them, it might not be a pain, but as soon as you say pain, it becomes a pain. And the next one is utilize open-ended questions where appropriate. So you can try to probe into a little bit more of the history, give them a chance to actually speak rather than yes and no questions. Okay, so that takes us on to, have they visited another therapist, GP, health professional, whatever, regarding this complaint? So this is all the stuff I kind of want to find out before I get into the real nitty-gritty of the actual injury mechanics and stuff. You can pick up quite a bit from this. I had one, it was last week, in fact. I don't do acupuncture, it's not my thing, but I'll use it as an example. Guy, chronic back pain for years, on and off, he's getting on a bit. And he's been to his GP, they're giving painkillers. He's had steroid injections, didn't work. Worked for a little bit, went for another one, didn't work again. Went to see a therapist over a year ago. They did acupuncture on it. No, it's rubbish, didn't work. So if I did acupuncture from that, would I use acupuncture on that person? Probably not, because they've already kind of told me it doesn't work for them. So it's picking up on these little bits about their beliefs, really, which leads nicely into the next bit. Probe the client's thoughts and beliefs about the condition and symptom. I've got a slide next, which I've seen a post on social media a couple of days ago while I was putting this together. I was like, oh, that works very well for this. So finding out what they actually believe themselves, and actually, their thought processes behind why they're actually coming to see you, be a really, really powerful thing. So from this initial conversation, you can create a list of priorities of what you need to delve into a little bit more. Complaints, I just call it P1, P2, P3. So that's how I kind of list it. The reason I do that is the amount of times you get somebody coming in, I've hurt my neck, and also my shoulder, and my knee, and this, and it's like, right, which is the main one, right? That's number one, right? That's number two, right, we'll get on to number two and number three if we get time, but let's concentrate on number one. But also, if it's a neck and a shoulder, have a conversation about both, because there might be a good chance that both are linked together. So, seeing this post, if it's not on full screen for you, you might struggle to see it. It was, so Adam Meekins put it on his social media the other day, which, I thought it's very patient-centric, which I really liked. And it was 10 useful questions to ask your patients. So I'll go through them quickly, just in case people are listening to the recording of it. Number one, how much do your symptoms currently affect your life? Number two, how frequent and severe are your symptoms? What do you think has caused your symptoms to start? Have you noticed any pattern or reason for why your symptoms may worsen or improve? How much control do you feel you have over your symptoms? Notice he's never said pain in this, and it's always symptoms. How long do you think your symptoms will continue for? Have you thought about what treatments may help? Do your symptoms affect your sleep, mood, or mental health? And finally, is there anything else you would like to ask me about your symptoms? When I was writing the previous bit, I seen this and was like, this just leads on very, very nicely. So I thought I'd throw it in there. So that was on his Facebook. I'm guessing it's on his Instagram. It was only last week. So it's a good little, there was a good little discussion on there as well. So, okay. So after we've kind of found out that bit, we need to kind of get into if it's an acute injury or if it's an actual injury rather than a chronic kind of onset of pain. Few things that we need to kind of decipher and, you know, which will be useful for things going forward. So number one, mechanism of injury. If it's a knee, what have they done? How did they do it? When did they do it? And how long have they had these symptoms for? Symptom descriptors. You know, I just ask people to describe, it's okay, how would you describe your symptoms? You know, sometimes they may need a bit of a nudge. Okay, so is it, you know, where is it? What's the quality of the symptom? Is it sharp? Is it dull? Is it stabbing? That kind of thing. Sometimes they need a bit of a prod and a poke, but getting somebody to describe their symptoms can also be quite a useful tool because it can tell you quite a lot about where the pain is actually, or symptoms are actually coming from. Okay, symptom pattern, morning, night. Is it better with activity, worse with activity? Do they get night pain? Are they struggling to get to sleep? What's it like first thing in the morning? When they get up, start to move about, does it ease? Does it get worse? I had a very good kind of example of this the other day. I was like, what's it like first thing on a morning? He was like, oh, it's not too bad. What's it like on a night? Gets a bit worse because I work nights and I'm walking about. And I was like, actually, yes, you need to be aware that you need to kind of tailor the question a little bit for some people, because some people work on a night, some people, you know, so their symptoms will be different. So you probably want to tailor it a little bit to be, what's it like when you're asleep, rather than what's it like at night. Ags and easers, so aggravators. So what particularly aggravates it? What sets off your symptoms? What eases your symptoms? The severity of your symptoms. So this is, you can use different things for this: visual analog scale, pain scale. Literally just ask them to how severe they think it is. There's a lot of research out there about whether visual analog scale, pain scales and stuff are actually useful, and you know, we're not going to kind of delve into that for the purposes of this session because this is an overview. And the irritability of it. So how quickly do the symptoms come on? How long do they last? And how severe do they get? And how quickly do they ease off? So aggravators, easers, severity, and irritability can tell you quite a lot going forward, especially when it comes to the planning of the actual physical assessment. Okay, a few other things. These are all things, if you know, if you go through these level 3 upwards: social history, family history. What is it they do outside of work? You know, do they play football? Do they go to the gym? Do they have a family? Do they have kids to look after? You know, all these little bits are quite important. Job and professional history. Is their injury, is their condition stopping them from going to work? You know, if you've got a manual laborer who's got a shoulder injury and they've been told by the GP, okay, stop using your shoulder, it's not an option for them. We need to find out something that we can do for them or find a way around it to try and get them back into work. Past medical history. Probe this a little bit, because the amount of times you ask the next question, they say, oh no, I've got nothing wrong with me. And then you ask the next question about medications or drug history, and go, oh yeah, I take this, this, and this. It's like, well, what's it for? Because you've just told me you've got no medical history. So the drug bit, I'm going to bring up another screen in a minute. I don't know whether anybody's aware of a BNF, so British National Formulary. It basically gives you, it's a database of drugs and medications that are prescribed. So there's various ways you can get this. It's free on the internet. So you can just Google it and bring it up. Click on this and it brings up, so it's drugs, interactions, or you can download free apps as well. So I've got an app on my phone and my iPad, which I just use, and it updates constantly. There's also a child's version as well. So, you know, it's, I don't know what, I'll use an example of something that actually came to me the other day. So nortriptyline, guy being prescribed nortriptyline, having a lot of neck cramps, and also tinnitus. And I was like, well, that just sounds a little bit too convenient that you've had this. So we looked into it. One of the side effects of nortriptyline are cramps and tinnitus. So we've kind of gone, right, okay, maybe you need to go back to your GP and see what it is, because the drug was having no effect as well. So these are really useful things if you don't know what you're doing with drugs, because there is so many. Okay, sleep patterns. So sleep can obviously play a huge part in, you know, if somebody's sleep deprived, their perception of discomfort levels and everything goes through the roof. Stress levels go up, everything like that. So we need to kind of delve a little bit into this. Is it their symptoms which are stopping them sleeping? Is it kids stopping them sleeping? Do they just not sleep? Is something happening around that? If we can kind of get them a good night's sleep, you'd be surprised how many people suddenly feel a hell of a lot better after a good night's sleep. Activity levels, this goes for at work and gym, sports, that kind of thing. You know, because you can get a good idea of how fit somebody is as well, which is quite important when you're doing your physical assessment and also planning for what you're going to do treatment and rehab wise. Because you don't want to be going, right, I'm going to get you to do all this extra exercise if they literally are not prepared for that. Diet and hydration, I'll be honest, I am not a nutritionist by any stretch of the imagination, but still ask more hydration. I don't really delve to, like I said before, I don't really ask questions that I don't think I can help with a diet. It's not my kettle of fish. You know, if I feel somebody needs help with diet and nutrition, I've got people I can send them to. Do they smoke? And how much alcohol? So these are just general questions to ask. These are all from like level 3 upwards. Okay. Once again, this is a very, very quick overview of this next section. We are not going into red flags because it's going to be a separate presentation on one of the following chats. So lumbar spine symptoms, cauda equina symptoms, saddle anesthesia, problems going to the toilet, that kind of thing. Cervical spine, vertebral bacillary insufficiency. So you got your 5 Ds and 5 Ns. So diplopia, double vision, drop attacks, various other ones. I've got them on my form because I always forget them. And then your Ns are your nystagmus, numbness, and another one. I'll bring them up on screen afterwards. Okay. If you suspect any pathology, any serious illness, anything like that, and it may be related to why they're here to see you, we refer that person on. If you feel that the condition is out of your scope of practice, we refer them on. Don't be too proud to refer people on. If you're just starting out and you don't feel comfortable, you know, just say to people, look, I think you'd be better off getting a screening elsewhere, and you can come back and we can do whatever it is. If it's sports massage that they're after, you know, they're not going to disrespect you by being professional and referring on to GP, sports therapist, graduate sports therapist, physio, whatever they need. If you're a level 3, you know, that kind of thing, they're not going to disrespect you for that. Like I say, we'll go through red flags and all that stuff on a later date. Okay, so you've gone through the introduction. We've gone through the mechanism and the severity and all that kind of stuff. What is it we do with that? So the first thing I always do with this is determine what their goals are. And I literally ask them, what is it you want from this treatment? What is it you want to get out of this? What do you want to get back to doing? You know, because if it's, you know, somebody who they want to finish their rugby season, that's a good motivator for them. Somebody can't pick their kids up, that's a massive motivator. They want to be able to pick their kids up and look after the kids. They want to be able to put them down to bed. You know, it's determining that person's individual goals. Okay, some of you may have come across SIN factor before. So it's severity, irritability, and nature of symptoms. So I use this to some degree in my kind of planning. So how severe is it? So how high are their symptom levels, pain scale, whatever you're using? How quickly does that come on? And what do I think where the nature of that symptom is? Is it muscular, tendon, ligament, bony, neural? Because that will form the plan for the next bit. So if it's really severe, if they're telling you they've got 8 out of 10 pain just sat in front of you, how much are you actually going to get them to do? How much realistically are you actually going to be able to do with them? If they're saying, oh, it's a 4 out of 10, but as soon as I stand up and bend over, it goes up to a 10 out of 10, and then I can't walk for an hour. Are you realistically going to bring those symptoms on that quickly? Because it will influence the rest of your session. And also, the nature of the symptoms will kind of help you form a plan of what you're going to test in the next section. So you form your assessment plan based on the findings of that. And that SIN factor bit is quite a nice little way of summarizing just that initial bit. Okay. We're going to go on to the objective and physical assessment. Before we go on to that, has anybody got any questions, anything they want to ask about all that bit before we move on? I'm going to take that as a no. Okay. So, little thing I put on here, only use assessment techniques that you feel comfortable using and that will actually add some clinical value. Fresh out of uni, I did this exact same thing. When I first graduated years ago, I was like, you get a shoulder injury, right, I need to do all my special tests. And it's just because that's what you were taught. You were told to do the special test to rule everything out. I'll be honest, we'll get into the discussion later on this one, but I don't really use that many special tests. But, you know, what's it actually telling you? How much time does it take to go through every single test? Also, if you're not trained to do these, but you've seen them on, you know, if you don't know how to do that and you're not comfortable doing it, just leave it out. There's another way of finding out what you need to know. Okay, so in your objective and physical examination, leading on from the last section on the subjective, what are your priorities? What is it you need to find out in this session from this person? What tissues do you need to assess? Which body parts and joints do you need to assess? Of those body parts and joints, what movements are available? Which ones do you need to test? Which ones you probably, you know, that's not as important. If you push for time, you know, you need to prioritize and keep it as concise as possible. Postural assessment. Do you guys use it? I can't see it. Everybody's put their cameras off, so I can only see Anne. Anne, do you use, just nod, do you use postural assessment? You do. We'll get on to this discussion afterwards. So what to look for and is it reliable? I personally, I use it, but I don't pay as much lip service as what I think I did years gone by, especially if it's the first time I've met this person. If it's the first time I've ever met this person, they could have, if this person's 40 years old and, you know, one shoulder's high, and it may have been like that for 30 years. And then all of a sudden I'm going to go, right, yeah, shoulder's higher than that one. That's what's causing you pain. I'll look at it. I'll make a couple of notes because it might be important later down the line, but I don't really say anything about it at that point. So I don't want to start catastrophizing stuff at the very, very beginning before I've even done anything with them. What I do is on that initial assessment, we'll use knee injury. You know, are they fully extended? Can they not fully extend? Are they actually weight bearing on that? Are they protecting it? Is there swelling present? You know, is there signs of inflammation? You know, what's happening at the ankle? What's happening at the hip? Are they shifting weight? That kind of thing. So I kind of look at that. So, you know, protective kind of mechanisms they may be using. Okay. First one I personally do, and I've kind of flitted around with how I've structured my assessments, is functional movement. I struggle with the way I actually worded that functional movement, because some of this stuff, what's functional? Every movement's functional. But I need to kind of categorize it in some way. And the important bit for me on this bit is I look at how they move, not how I tell them to move. So, and I use just general movement patterns. I had one the other week, lady with a shoulder, you know, she's struggling to lift her shoulder. Or is it, oh, I was closing the curtains. Right, how do you close the curtains? Show me how you close the curtains. Can you reach something off this cupboard up here? Can you lift, get that down for me? I want to see how she does it, you know, because that's quite important, rather than just going, right, that. Because ultimately that's how people move. They don't move like robots. Examples: walking, running, if it's available. I've got a treadmill on the back, it never gets used anymore. Squats, and the many variations of squats are I find quite useful myself. People stand up and sit down a lot. Bending over, you know, and it's not like hip hinging, bending over. Right, pick that up off the floor for me. How do you pick it up? Move it to one side. Right, pick it up from there. Sit them down. Right, can you pick this up off the floor? Twisting, balance, single leg. You know, there's loads of different variations of balance stuff. You know, you can just get them to stand. Balance exercise. There's the star excursion balance test and Y balance if you want to quantify it a little bit. Press ups and many variations of press ups, that kind of thing. So these are all good kind of global movements that you can use. If any of these reproduce their symptoms, where does it produce the symptoms? How severe is the symptoms? And also, can you modify it? I had, once again, I'm going to use examples through this. I had a lady come to see me. She's very knowledgeable about anatomy. She's a doctor in a hospital. She also likes to keep fit. And she told me she had very sharp stabbing pain in her coccyx. Can I help with this? And I was like, we can come in, we can screen it. And if I can't help, we go somewhere else. It wasn't a coccyx, it was coming from more sacrum and kind of lumbar region. And it was all on one side. There was no neurological symptoms, no red flags. I was like, one of the questions that came up, it really hurts when I do tuck jumps at CrossFit. Okay, but it all hurts on one side. And that is a massive movement. Okay, so we test, right, just do a squat for me. Wide feet, wide hips, externally rotated, feet pointing out, goes down, like, feel it there. Well, legs were really far apart, really externally rotated. All I did, bring them in, knees facing forward, pain's gone away. Literally just doing one little thing, modified that movement, just made it massively different. I also noticed when she was sat in the chair, she sits with her legs crossed. So her left, it was all on her left side, her left leg was crossed over, so it's stretching. You know, so it's these little bits that you can pick up on. It's not just the movements that are in front of you, it's also when they're sat there. She's a doctor, sat in a chair talking to people in that cross-legged position. She gets up, moves around, she's probably a bit stiff, and then she's going to try and do a tuck jump. Modifying that made a massive difference and gave her huge confidence that we could do absolutely loads of rehab, because it decatastrophized her symptoms straight away. Because she was like, actually, no, I can do it. Okay. What is produced, what is aggravated, what is eased the symptoms? And that kind of goes on from what we just said there. Okay, active range of motion. Before we go into this, anybody got any questions? Just raise your hand, stick it in the chat if anybody's got anything. Just have a look. No, there's nothing in the chat at the minute. Okay, so active range of motion. Like I said, we're going to plan out what movements we're going to do. Don't just do all of them. What are we looking for? range, the quality of the movement, and the confidence of their movements. How do you measure and quantify it? Yeah, let's bring up back to this screen. So for a few different tools I use personally. First one, tape measure, use that for various things, swelling, that kind of thing. Some of you may have seen these before. Clinometer, basically you tilt it, tells you how many degrees you moved. They're about £4 on eBay, really useful. Or you can download a clinometer app on your phone for free. Just be careful that you don't drop your phone. Goniometers, I've had this one for absolute years. Don't really use it anymore because I found something else, which was it's a ruler which moves through an angle. Found this. So rather than me having to use maths, it basically tells you, so you zero that, put it where you need to be, works exactly the same as a goniometer, move it through, tells you exactly how many degrees. Go back, goes back. Other thing I've got a dynamometer, which I don't use that for range of motion stuff because it just takes too long. That is far too easy. If you don't have those and you're eyeballing it and it works for you, fine, but I would question how reliable and repeatable that is. If you're wanting to see how much external rotation there is and you're just comparing it to the other side, you may, when you're switching between sides, you might go, oh, that's the same. But 5 degrees is probably quite subtle, but might be quite important in that time. So I can't remember what that's called. I'll put it in afterwards. Found it on Amazon, about £10, cheaper than a goniometer and easier to use. Okay, like I said, I'm going to choose what ranges we do. I'm not going through all this because we're going to do these when we get into the specific joint sessions later on. Passive range of motion. So this is what you do. So the active range of motion is the movement that they do. Passive range of motion is the ones that you do. Do active first because you don't want to be pushing things into ranges that they really don't want to be in. Their shoulder hurts here. If you go in first and rag it up here, it may cause further. You're going to lose their confidence straight away. With passive range of motion, hand position and control is the most important thing. If they don't feel like you've got hold of their limb and don't feel confident, you are not going to be able to get a reliable kind of test from this. Looking for range. So how much can we take it further than they can actively? Is there an end feel? So different joints have different end feels. Does it feel like a normal joint end feel for that? Is it hard? Is it soft? Is it bouncy? Are they protecting it? So if you're going into these extreme ranges and you can feel them fighting you, is it because they don't want you to take it any further? Or is it because they just don't have the confidence in you're just not doing it? Same again, how do you measure and quantify it? A little bit harder using a goniometer and everything, but it is doable. That's where these little clinometers, I don't know where to put it, there is. These ones come in are quite handy because you can hold it in place while you do your joint. Symptom reproduction and clinical relevance of the passive range of motion. General rule of thumb, active range of motion is contractile tissues, passive range of motion is non-contractile tissues. So if it hurts when they do it, it could be either or because, non-contractile tissues are going to be involved when they do it. If you can get them to relax a lot and you're taking it and the pain disappears, that kind of backs up the theory there. It may be contractile or involved in contractile tissue. If it hurts more when you're doing it and you can take it further, it may be non-contractile tissue that you're setting. Okay, strength. So you've seen how much they can move. You've moved them further, hopefully, and you want to see how strong they are. Loads and loads of ways of doing this, absolutely loads of ways. You don't need loads of equipment to do it. You don't need any equipment technically, but what what tests are you going to do? What are you going to be testing? Are you going to be doing joint specific stuff? So if it's an elbow, you're going to be doing elbow flexion. If it's a knee, you're going to be doing extension flexion. So we'll stick with the knee. Or are you going to do a squat or a mid-thigh pull or that kind of thing? What kind of contraction are you going to use? Are you going to use an isometric? Are you going to use isotonic, isokinetic? Isokinetic's probably quite hard without an isokinetic machine. Which ranges are you going to test in? So if it's an isometric test, whereabouts in that range are you going to test it? If you're doing elbow, is it going to be mid-range? Is it going to be end range? Where are you going to test it? What are you testing? Is it max strength? Is it endurance, or is it the power? So you need to kind of think about how you're going to test for these different things. So if it's endurance and it's an isometric, is it how much force are you going to put through it? You know, or is it how many squats they can do in a set amount of time? You know, this kind of thing. Once again, how do you measure and quantify this? So a couple of things I have. So first one is a crane scale. These suddenly became dead popular. They're quite heavy, but they are very useful, and they go up to 300 kilos. So basically what you do is, it comes on, let me just check that zeroed. Pull on it, it tells you how hard you're pulling on it. So these are good for like gross movements or bigger joints. So mid-thigh pull, kind of squat, isometric calf raise, you can do shoulders, so you can have it tied. But I use a chain and a handle. So I've got thing on here, so chain goes around there, it goes underneath the squat rack, and then I've got another chain with a handle, so just all off the multi-gym in the background. Other things I've got, grip tester, picked that up off online for about 20 quid, I think. Vary between 20, 40 quid. They're all the same thing, I think. And like I showed earlier on, got a dynamometer as well. So use this one quite a bit. It was about 300 quid. So these are quite expensive. And they do take a bit of setting up, and they can be a little bit time consuming. But the thing you get with these is they are very reliable at giving you good results. And you can save the graphs from all these. So they are good things. This is the Active Force 2. There's a few others out on the market as well. There's a new one that's just come out called the Vald, which looks quite good, but they are expensive. But it does give you a way of quantifying basically what you're doing. So if you've got an athlete and you're wanting to test how much knee extension strength they've got, you need a way of knowing how much knee extension strength they have now before you start kind of dishing out exercises and stuff with a target. And you need to be able to kind of show them how much they're actually doing. Once again, don't just do strength tests for the sake of doing strength tests. If it's not going to have any clinical relevance for you and how much it's not going to influence your treatment plan or anything like that, don't do it. Just choose the techniques and the protocols that are useful to you and useful for your further planning. 2 seconds. Okay. Bit of a controversial one in this bit as well. Some people use them, some people don't. So the accessory movement, joint movements, I actually do use quite a lot, especially on ankles and shoulders, wrists. I use accessory movements. For those who don't know what an accessory movement is, it's based, so you've got physiological movement. So if I'm doing shoulder abduction, what happens is the humerus in the glenoid will also move. It doesn't just move like this. It rolls and glides and twists in all different positions. So those other movements are the accessory movements. We can kind of influence those. There's various theories, the convex concave theory about which one you move, which on the convex surface and the concave surface. I'm not going to get into all that. Once again, there's a lot of research about it's some people say it's very relevant. Some people say it's not relevant. You know, we're not going to get into that on this one. PAVMs, for those who don't know, passive accessory intervertebral movements. So these are the ones where you're pressing down in between and you're moving the vertebrae up and down or twisting unilaterally. And PIVMs, which are passive physiological intervertebral movements. So that's what they do. So when you're moving to side flexion, extension, but these are passive. So it's you moving them into extension, into flexion, into side flexion, rotation, etc. And testing the joint, basically, you're testing for joint stiffness, apparently. I'll be honest, we went through loads of this at university, at degree level and at master's level. I use the PAVMs, so the accessory one. I do use them now and again, just as I add them on the end as more of a confirmation. The PIVMs, so getting people sat there and testing these tiny little grades of movement in between vertebrae. I don't personally use them anymore because I found them very time consuming and I didn't feel like I was doing it correctly and I didn't feel like I was getting any value from it personally. That is probably my skill set. If I carried on practicing, I might pick up more. So I'm not knocking those people who do use it. But for me personally, there's other ways I can find out that information. Okay, so with your accessory joint movements, PAVMs and PIVMs, they are joint specific. Which movement are you going to test and why? What range will they be in? So I'll stick with the shoulder because you can see my shoulder. So if you're doing an anterior to posterior glide, where are you going to have their shoulders? So anterior, so when you're doing it, it's going to move the humerus backwards on the glenoid. So it's going to go backwards into that direction. So you place your hand here and you move it backwards. Are you going to do it in neutral? Are you going to do it in abduction? Whereabouts in abduction you're going to get it? You're going to do it in flexion. Because if they're getting pain up here and you're testing down here, how much clinical relevance is that actually going to have? Because they might be fine down here, they might have loads of joint play, it might be fine. But as soon as you go up here, you might find it's very stiff, you know, but also, is it an external rotation? Is it internal rotation? So it's the accessory movements will change and it's about selecting the right ones in the right ranges. What grade selection? So for those who don't know, it grades, so without manipulation, it goes 1 to 4, 1 being tiny little one at the beginning of the movement, 2 being up to mid-range, beginning to mid-range, 3 from mid-range to end range, and that's the physiological range of that accessory movement. And then grade 4, the tiny amplitude one at the end of that. Grade 5 is the clunk and the click, the manipulation. However, using grade, if you use these as a diagnostic, so using a diagnostic PAVM, so an passive accessory intervertebral movement, and you're saying you're doing a grade 2, is it a grade 2? My grade 2 is probably somebody's grade 3. My grade 2 maybe somebody's grade 4. You know, so the clinical reliability between it, as long as you can justify it, crack on. Okay, so we spoke briefly at the beginning, special tests. Absolutely hundreds and hundreds of special tests out there. How reliable they are, how specific they are, you know, there's a lot of research out there about how actually are they doing what they say they do. You know, if you're doing an empty can test and you get out here and you turn it in, or, you know, a chromium impingement, you know, is that actually doing what it says it does on the tin? You know, do your own research on this kind of stuff. Only do the ones that, once again, don't do what I used to do when I first started practicing and just do every special test under the sun, because you're just wasting your time. And all you're going to do is just aggravate those symptoms, and then everything will become positive. When it comes to special tests, you're better off doing your own research and also using them and seeing which ones you actually like to use or actually find some clinical relevance from, and see how effective they are for you, rather than me going, right, here's a load of special tests, here's this, here's the Jobs, here's the, you know, the lag test, all these ones, there's hundreds and hundreds. make your own decisions on those, you know, because what I will say is the special test should be done as a confirmation. You know, you should, by this point, you should have a good hypothesis of what you think is going on with that client. And this should be something that's going to add actual value rather than just doing it for the sake of doing it. Okay, palpation. So people put this in different places. So I want a couple of people to unmute. And I can see you, everybody else has kind of got everything. If you're doing an assessment, whereabouts do you put palpation on your? Wait for Anne to unmute. There we go.
Yeah, so probably in a couple of different time frames, really. Sometimes in that very initial assessment, just if you're observing, you know, some range of movements, it might, you know, involve it there. Or then obviously once I've got them in a position prior to treating, I will do a bit of palpation prior to doing anything else.
Yeah, I think Ryan just put on there. I'm just going to read it from the chat. Depends on the case and if it's needed. Absolutely. I personally, we were always told to do it at the very beginning. I try not to now. But like I say, it just goes exactly, you know, what we were saying earlier on. It fits in around what you do. You know, it's what works for you. If you want to put it at the beginning, put it at the beginning. I personally put it as late as possible. You know, if I think something's on the anterior of their shoulder is sore, and then the first thing I do is stick my thumb in and stick it in and it hurts, and then I'm going to get them to move. I've already, you know, for want of a better description, poked there, made it probably a little bit angry and a little bit sore. Is that then going to affect the outcome of the follow-up bits? Whereas I tend to use the palpation bit more of a confirmation of what I think I'm finding as I'm going through. So if I'm moving through shoulder, it's like, right, okay, what could that be? Okay, I've done the active, I've done the passive, I've done the accessory. Okay, don't get me wrong. Yes, my hands are on, but I'm not specific palpating structures. You know, I'm trying to be as global as possible with this. What is it you're feeling for? You know, there's different ways of palpating. You know, if it's an acute injury, yes, no, that's swollen. I'll use it quite early on. Right. If the swelling's not obvious, I'll palpate the joint, find out what's, you know, there is swelling there, there is heat, that kind of thing. Yeah, that's fine. Different scenarios, you know, pitch side stuff, you need to get in pretty early. What is it you're feeling for? And how specific actually are you? Are you feeling what you think you feel? You know, so if you go, right, I'm palpating this ligament, and are you, or is there another structure on top of it? If you're palpating this muscle and, you know, are you actually palpating that muscle? Are you on that muscle, or is there several layers on top of it? You know, and yes, it's going to hurt because you're pressing quite deep. So this is why I tend to put it at the end, because if the first thing I do is cause that person pain, just by sticking my thumb or whatever into whatever joint or body part, you can lose their kind of confidence quite quickly. You know, so it goes back to the very, very beginning about making a first impression. You know, if your first impression is, right, I'm going to stick my thumb into your hip and it's really going to hurt, they're probably not going to want you doing much else after that. Put it in where you feel you want it in, though. Like Ryan said, it depends. Catherine has just come in with a comment as well. Usually when the client is on the massage table, sometimes they find it's not always where they're feeling the symptoms. Yeah. So it's when you feel it's appropriate. Sometimes if it's going to bring value to what you're doing at that particular time, do it then. Okay. We are not going to go through a full neurological examination. I was quite surprised to find out how many graduate sports therapists had never done neurological examinations before. when I think it was around the time we had John Gibbons on the chat, because I just thought it was a given, but I was wrong. So I'm planning on doing a session on different neurological kind of tests and screens and stuff like that at a later date when we kind of get to it. But a few things to kind of pay attention to when you're structuring your assessment. What neurological symptoms do they have? Do they have neurological symptoms? Do you think they have neurological symptoms? They're getting shooting pain down the back of their leg, like sciatic type symptoms. Yes. Are they getting pins and needles? Are they getting numbness? If they're getting a neurological type symptom, are you going to assess neurological structures? I personally would, but this comes back to what your scope of practice is, I think. If you've never been trained in it, don't feel comfortable doing it, there's other ways you can achieve the outcomes. One thing I would say, one of my lecturers kind of told me this, and I was like, yeah, whatever. And we were doing the testing, we were going through stuff at university. And I didn't realize I had a sore hip. And then we were going through all the things. Don't know why, whenever we were at uni, I was always the person who was the model, and I was always the person getting demonstrated on. And I went through absolutely loads of lower limb and upper limb tension tests. Felt fine. This was Monday. I think we were done by 1 o'clock on Monday. Felt fine. Got up the next day, and I was in absolute agony. My hip was on fire. I had shooting pain into my glute, everything. I've had issues pulling the nerve on both sides before, and it really, really aggravated that. My little finger was numb when I got up on my left hand. Everything was down my left-hand side. That's because neural tissue symptoms can have a latent response. So if you are doing neural testing, or if you give neural exercises, you know, neural slider, floss, if you give that kind of, don't go, right, do loads of these, because they may feel fine doing it at that specific moment. But the latency of the symptom response can be 24 hours-ish. You know, it can be an hour, 24 hours. People react differently. But if you aggravate that too much, you are not going to know at that specific moment. And the next day, they could feel like they've been hit by a truck. Because that's exactly how I responded. I'm not saying that's the same for everybody, but be aware of it. So, do we think it's peripheral or central in nature? So, central being spine, brain, peripheral, everything outside. How are we going to test for those? So, we've got dermatomes, so the skin sensation, the innervation of the skin and the dermis. Has specific patterns, how accurate those patterns are, but you can still get a good idea. You can start to paint a picture with these. So if somebody's got neck pain and they're getting a little bit of pain from your previous things around C6, and then the C6 nerve roots, dermatome is also a little bit sensitive. And they've also got a myotomal deficit on C6, C7. You start to paint a picture of, like, actually it's probably C6, C7. Your neural tension tests, these are for peripheral stuff, but they can originate from the spinal level. You've got your upper limb tension tests. There's one for radial, medial, and ulnar. 2 for radial. I can't remember if it's radial or medium. Straight leg raise and slump test. So they're all neural tension tests. So these can kind of, once again, confirmatory tests of what you think has already been going on. And also reflexes. I use a reflex hammer. It's a skill in itself doing reflexes. Knees, I'm very good at it. Biceps, I'm very good at. Tricep one, I'm terrible at. Ankle ones, terrible at. So I just don't do them. Another comment in the chat, 2 seconds. I wasn't taught it at level 4, picked up some information through some of my clients who have neurological conditions, want to Charcot-Marie tooth disease. You're going to have to tell me what that is. which has caused muscle wastage and nerve damage in one of her legs. Wow. Catherine will get you on in a minute and we'll discuss that. Yay. So we're on to the final little bit now. So we've gone through your subjective, your introduction, your active, your passive, your strength testing, your palpation, your neurological assessments. And it's now starting to put a plan together of what you are going to do for this person. What is the best course of action for this person? It's at the bottom, but I'm going to put it back to the top. First and foremost, whatever we do with this person needs to be safe and effective. I think as practitioners, that's one of the most fundamental things. What we need to be doing is safe. Don't put yourself or that person in harm's way. Don't be getting them to do things that are probably they're not ready for. As we've mentioned several times, consider the client's personal aims as well as the clinical findings. So you might go, right, I want you to do squatting, all this, I'm going to get you deadlifting, I'm going to do. If that doesn't tie in with their personal aims and what they think they want to do, if they don't want to go to a gym to do this, you are not going to get a buy-in. You need to find things that fit around them. So it's not just your own personal beliefs about and your own biases about what is going to get them better. You might love to go into the gym and go to the gym 6 times a week. They may not have been to the gym in 20 years, so they may not like weightlifting. So it's about easing in these little bits. What are the likely causes of the patient's symptoms? So that's quite important for what you're going to be doing. So that's coming from your objective and your subjective assessment. As I've just mentioned there, what's the best course of action to help this person? So this is like where you need to start planning, right? What is the best treatment plan for this person? Are your choices appropriate for that person? Like I've just said there, it's not, you go to certain NHS or I did placement at a physio who everybody with back pain got the same handout with the same 4 exercises on it. For some people, it might be quite appropriate. For some people, they're quite fit and healthy. It's just not appropriate, And I'll go back to that first comment, be safe and effective. So in whatever you choose to do with this person, whether it's hands-on treatment on the bed, physical rehab, or it's stuff you're giving them to do at home, it needs to be safe and effective. Because if it's not safe and if it's not actually going to work, what's the point of it? Okay. So last bit. So clinical reasoning. Don't know whether you can see that. I'm going to highlight this 2 seconds. See if you can see that a little bit better. There you go. Maybe I'll see that. So something I kind of picked. I'll be honest. I started using this a long time ago, and then I kind of moved away from it. But for the purpose of this, to kind of get across the clinical reasoning bit, I think it's quite useful. So if you want to be forming a plan about how best to treat this, and there was an interesting discussion yesterday on the STA page about diagnosis. And what do we do? Because we can't diagnose, because we're not we're not medically trained. So technically and legally, we cannot offer a diagnosis. So what do? We clinically reason from what we found. Does it? I'll be honest, I stopped putting names on things a long time ago, because I found a lot of people, and I go back to one of the comments, one of the things we discussed earlier on about people being to see other therapists, and they've been told things. I had a guy who came to see me just after Christmas, who told me he had 3 bulging discs in his neck because this pain specialist he went to in Leeds told him he could feel them through the back of his neck. And I was like, what? So he's been diagnosed with 3 bulging discs in his neck. So that, you can just imagine how bad the outcomes were with that. As soon as you put a name on something, they seem to wear it like a badge of honor. So I stopped kind of using it, to be honest, and just went, you think they're probably coming from this. This is how we deal with it. you know, make it as simple as possible for them because they just want to know how they're going to get better. So a nice simple chart to use with this is start at the beginning, symptom or complaint, subjective findings, and I'm talking key subjective findings, physical findings, and like the key points from that. Other contributors, that could be the alcohol, the sleep, the stress, the kids, the family, that kind of thing. And this is where you start to go, right, I've labeled it hypothesis. Okay, hypothesis of what you think is going on. Where do you think this symptom is coming from? What do you think? Don't be afraid of having a couple of hypotheses. Don't burden yourself with going, right, I need to come up with something for this. Because sometimes you don't need to. You know, you can have several different ones. What are your treatment aims? If it's an acute injury, it may literally be, we need to reduce this swelling. We need to reduce your swelling and get full active range of motion. You know, if it's a chronic problem, it's going to be different aims. So from your hypothesis and all that stuff, just muting your Ryan, we go to the treatment plan. And this I find works quite well as a discussion. Okay, this is what I think is the best course of action. How do you feel about this? Is there anything you want to change? You know, make it a discussion, because then it becomes personal to them, especially if you're going to be given rehab. You know, you need to know they're going to actually do this. And if I send people away with exercises, I tend to kind of do them in here first. But when I send them to them, they know what they're doing, rather than just getting a picture on a sheet and a very interpretive description. You know, I use Rehab My Patient. I've got a lot of my own exercise on there. You know, and the videos are great and stuff, but it's how that person interprets. And sometimes you might need to actually change it slightly. If I want somebody to do, I don't know, if we'll use press up, they may not be able to do a press up. So I need to come up with a different solution for them. But unless I do that in here, I'm not going to know that. But then they get the buy-in, because if they go away and you're telling them to do a press up, and on day one out of the clinic, they go to do a press up and can't do it, when they come back to see you, they are not going to have done anything. So I find it's quite good to get them involved in that discussion. So that's a good little clinical reasoning thing. I'll put, what I'm going to do is I'm going to save this as a PDF, and I'll put it in the file section of the group as well. So if you want this chart or anything, or if you just want the chart, just give me a shout and I can email it over to you as well. Dead easy. A good book, I think this is the old version now, for kind of subjective stuff, is this one. It's Neuromuscular Examination Assessment. It's by Nicola J. Petty. This is an old version where I got off Amazon for about 10 quid. The new versions are about 50 quid, but it's a really good book. You know, you can pick up some little bits. Like over the years, it's kind of helped me a little bit. The new versions are probably obviously a lot more up to date, a little bit more up to date evidence, but I found that quite useful, to be honest. Okay. Right, that is presentation bit over. I kind of want to have a discussion with you guys, because that was my take on things. I want to know what your guys' takes on things are. So you can all unmute. Nobody's unmuting. There you go. Everyone's going. There we go. Catherine, you brought up a couple of bits in there. Obviously, the good thing about this is, and the reason I wanted to make it a discussion, is because everybody's different levels, different backgrounds. So I thought it'd be quite useful to have that. Yeah. Useful, not useful, pick up anything you agree with, disagree with.
I've learned maybe a bit differently because I'm level 4, so I'm not physio or sports therapist trained, but what we learned was more, we did learn to do subjective and the active passive movements and that kind of thing, but I find I don't use them as much. Okay. I will use them, I think it depends on who you're seeing, but majority of my clients are people that have been in lockdown and sat at their desks or dining tables. So it's usually shoulders that are stiff from sitting in an awkward position for a long period of time. So that's all I usually see. But if I do get, because one of my clients who's also based at my gym, she has Charcot-Marie-Tooth disease. So I've actually learned from my clients. So picking up on different neurological issues and how she's dealing with it. She can deadlift like 130 kilograms, you know. So she knows how to work around it, but then sometimes she'll ask me for advice and I'll look at different exercises that might help work the muscles that are still working in those areas. So it's working with them as well. So it's not kind of telling them something, but it's more working together to see what works best for her.
Yeah, especially if you work with athletes,
Yeah.
a lot of them are very, very body aware. You know, that's why I think that bit at the beginning is like, what do you think's wrong? You know, I think that can be quite a powerful thing, because it's like, okay, right, let's see if we can, you know, and sometimes, a lot of times they're probably about right.
Yeah. And I learn a lot from just the discussion, even just on the massage table, because they're getting a more relaxed frame of mind. They're getting to know you, because they haven't, if it's their first time seeing you, they won't know you that well, so they don't know how much to give you. So if they're feeling relaxed and you're being relaxed with them, hopefully they can tell you a bit more information that they may have not filled in the form, that they may have not put on the form before seeing you in the first place. So you learn a bit from the form because you've asked certain questions anyway in that. But like I put another comment about parents, like knowing the history. Sometimes you won't put that in your form about what illnesses might be in your mum and dad, because of, like, I've found out that a mum had myasthenia gravis, and then the dad had a stroke, and she was having issues lifting her left leg during a PT session. And I was like, I think maybe you need to look at being referred to a GP, because she'd lost a lot. She couldn't lift her leg anymore. So I was like, I think that's a GP referral. So I still treated her, still was fine with it, and treated her for other things, but it was definitely a GP referral for that one.
Yeah, I think it might have been you I had a discussion with about the massage bit, actually. If I feel somebody is a little bit kind of tensed up and a bit on the first session, I don't like to use massage as like my sole treatment thing. I'm very exercise based, but sometimes just that, right, you want to lie down, well, you know, because some people, they like it and they enjoy it. And I continue to just have a chat. So throughout all of that, the subjective assessment doesn't stop as soon as I start to, you know, I put in, so my first sessions, I do an hour and a half for the sole reason I want to make a good impression on that person. And I don't want to rush it. I want them to get to know me and me to get to know them. And so I asked them about the kids. I asked them about different things. And the amount of times I've actually picked up things, there was one lady was having shoulder pain. She was a runner, and she wants to get back to ultra running. You know, she's hit 50 and she's having loads of problems in her knee and in this, and she was like, oh, I'm struggling with swimming because I can't breathe, because I'm struggling to get this out. And then we were just chatting, and I think it was about 6 years ago. She was on holiday and she'd gone down a water slide, and then somebody had come behind her. She'd looked to the side and they'd hit her in the head, and she got concussed in the water. I was like, you were looking that way. That's the way you're struggling to breathe. Okay, let's do some stuff. And we did some vestibular, just really basic vestibular assessment on her. And as soon as she moved that way, she got dizzy. She got all sorts of symptoms. As soon as anything looked over that side, any kind of torsion, I wouldn't have found that out unless we're just having a general chat. Because that wouldn't have come up in a subjective assessment, because it's a bit clinical.
Yeah.
Whereas that's just a nice, relaxed conversation. You can find the same sort of thing, exactly what you just said, Catherine. I think getting people nice and relaxed, get them on the massage bed, just have a chat.
Yeah. Yeah, so that's mainly where my subjective assessments come in.
Yeah.
Is on there.
Yeah, I definitely agree with that. That it's that all ongoing gathering of information, you know, through all these first clients. So, and I'm like you, I do tend to put in an hour and a half in the diary just in case, because you sometimes you just don't know. They might have called you or contacted you about one problem, but actually there can be, you know, several things ongoing. But one of the pieces I was interested in maybe others. Kind of how it operates with them. So I work quite closely with an osteopath as well close by. So it's working very well now, sort of either direction, where I've had some cases where I'm only level 3/4 as well. So hit a point where I've done what I can do, loosen up muscles, etc., and referred them. And then the reverse has also been happening where he's felt that somebody would get more benefit from being at the osteo with having their muscles more loose. So then they refer back to me. So that's worked quite nicely. But where we get a lot of the new clients that talk about, you know, they've been to a physio or they've been somewhere else, and like you say, they've got some diagnosis, which may be true or not true. Yeah, so I guess it's that way of, I always listen to what's said, but then obviously make my own judgments as well. So it's how do we best manage that information when it's given to us, whether we believe it or not.
Yeah, and I think it's, you know, if you don't agree with the diagnosis, they may believe that's what it is. It's about not going, nah, that's wrong.
Yeah.
I'll be honest, when the one I told you earlier on about the guy who said he could feel bulging discs through the back of somebody, that one I went, never go see that person ever again. Because whether that guy actually said that to him or not, that is the message that he has took away, you know, which is quite, if that's the message he's come away with, then he said something in that to make him believe that. So that's why I say be very careful about like the language you use, and using negative language and putting words in people's mouth, because they could go away and go, oh, he said this, you know. So I always try to get people to say, right, what is it you're going to go away and tell people? So I'll summarize near the end. We'll have a bit more of a chat and go, right, what are you going to tell your wife? What are you going to tell your partner? Because then you pick up how much they've actually listened and how much they've took away from the session as well, and like how they've actually interpreted what you've told them, because that's your chance to maybe I don't want to say put things right, but if they've misinterpreted something, that's your opportunity there. Anybody else? Right,
Yes.
so you're unmuted.
Yeah, so something Catherine said about just being a level 4 sports massage therapist, don't discredit what you do. You know, I started out level 3, level 4 sports massage, moving on to level 5 and stuff like that. So, and I work with a local rugby team, and there was a lad that's gone away, and a few different other things, has not been able to participate in the last season. And he's gone through the NHS, through their physios and stuff like that, and they've given him different things to do, and he's not happy with what they've said. He's come and spoke to me. Now I'm going off your way of thinking, I'm only this, I'm only that, but there's a few things that I noticed through having a conversation and things like that. It says, first things first, you need to go back and tell them what I found. Then you need to get yourself referred back to go and see your specialist about your brain. You need to go and get a scan. I didn't really say what it was, but it turned out I spotted the red flags by having that conversation, getting him on the couch. Turns out he's got MS.
Wow.
So don't beat yourself. And this is another thing about having that conversation with people as well. It shows you how important that is, and it's something that isn't taught in the early stages of people's career, especially level 3. It's like, you can't do this, you can't do this, you can't do this, but you can have that conversation. And I think from everything that you've said tonight, Scott, I think that for me should be highlighted a hell of a lot more. That conversation can save a lot of time.
Massively. And that, like, you know, I go back to, you know, You don't get second chance to make a first impression. You know, whether you're screening for flags, you know, if somebody doesn't feel confident or comfortable talking to you, they're not going to start telling
They're
you.
not the right client. And I will always, it works both ways. If my client will open up to me, but again, if I don't feel that I've got that connection with the client, I won't have any qualms in saying it's not going to work, but this therapist might be the one for you. You know, it works both ways.
Oh yeah, I mean, I've had ones where we've had to have difficult conversations with clients, and I've gone, we're not going any further.
No,
because you're not buying into what, you know, we've discussed everything. If you're not going to buy into principles and not going to help yourself, I'm not the right therapist. I'm not going to continue taking your money.
No.
You need to find somebody else. You know, and didn't charge him for the session because he was literally in there 5 minutes, and he just was like, I haven't done the exercises. It's the third time in a row you haven't done the exercise. Why? Couldn't be asked. Right, okay, we're done. It wasn't quite that blunt, but it was I was like, look, feel free to come back at a later date if you feel like,
if you feel you're ready.
Yeah, if you have a change of mindset, but I don't think I'm the right person for you. And I worded it like that. I'm not the right person for you, not that you're doing my head in. You know, I'm not the right person for you. Because to be fair, you know, I clearly wasn't motivating him right. And I see myself, one of the things I kind of say on my social media stuff is I provide education for my clients, you know, about how they can help themselves. I facilitate it by giving them the tools. You know, it was like, right, here's the things we need to do. So educate, facilitate. And then after that, literally my job is just to keep them motivated and, you know, make little tweaks. If I can't motivate that person, then it's the clinical relationship just isn't there, you know, and that comes back to the very, very beginning. If they're only here for 20 minutes at the beginning and kind of like, right, blah, 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 get out, they're going to struggle to make that kind of relationship. So, but that's just my personal opinion on that. You know,
sometimes it's to do with behaviour change, though, because I did the Dr. Gary Mendoza's motivational interviewing behaviour change thing course, and it is down to hearing out for certain behaviour, certain ways of phrasing. So it might be looking out for if they want to change or if they're going, I'll try. So if you're giving them exercise and they'll go, yeah, I'll try and fit them in, da, da, da. Are they actually going to change, or are they actually wanting to change, or are they just getting used to putting up with the pain? So it's looking out for certain phrasings, certain words that they're using as well.
I think that's what you said at the beginning, wasn't it? It's got about what's the client's personal drivers or goals. What is it are they trying to achieve through that? I know I got a big thank you the other week from a client of mine who's a triathlete, and I've just been helping them with a few sort of small, you know, minor things and keeping them race ready, as you like, as things starting up. And there was something we said the other about, you know, had like problems in his calf and then up towards the hip, and it was kind of a long conversation over a couple of sessions, but I still had this inkling about something wrong with his foot. Eventually I said to him, I think you need to go get checked, and which he did. Turns out he sent me this photograph of a fracture in his toe. So it was kind of obviously just that part of it gut feel that there was definitely something else going on and needed to be checked. And, you know, just as you say, just not be afraid to forward it on to someone else with, you know, those other skills as well.
Oh, I don't think I've referred so many people for x-rays than I have in the last few months working at a rugby club. The amount I picked up, there's been a couple of stress fractures. I had one guy who thought, I'll be honest, I thought he'd fractured his patella because he had a massive delve right across the full width of his patella, and he landed on his patella on AstroTurf, and his knees just went, and it was hot. Could have cooked an egg on it, you know, and it was like that. And I'm going through it. As soon as I pressed down, I was like, ooh, that creaks. Ooh, that doesn't feel right. Right, okay. And he didn't go. He did not go for an x-ray for a week. And he was like, I was too scared to. You scared me. I was like, I don't really know what you want me to say with that. You know, it's like, I think you might have done something. You need to go and get an x-ray. Tell me I broke my knee. I don't know, but we need to confirm it. And then he went away and threw his toys out the pram. But I've referred so many people for x-rays. Sometimes, you know, you get them kind of, well, who are they to say you need an X-ray? You can only do what you can do.
Yeah, definitely.
But it's, yeah, the ball's now away from you. The responsibility is now away from you. Elliot, I know your camera's not on, but feel free to kind of jump in. Ah, there we go. Hello.
Hey,
Hello.
yeah, just picked up on a couple of things. One thing I do at the start of the session is I've got myself a whiteboard at the start of every session. Obviously from a injury rehab point of view, I get them to write down 1, 2, or 3 things that they want specifically out of that session. And something I've picked up on is to bigger picture, try and get them to do it for 3 weeks, 4 weeks, a month's time to see where they think they're going to be at and see where it sort of marries up.
Yeah, that's quite a good little thing. So basically, right, set your own goals.
Yeah.
Yeah, I think that's good. It's, you know, getting people to actually, you've already got your buy-in then, you know, and it's like, you set this goal, let's get you to do it. You know, it's, you know, therefore it's not unrealistic, you know.
Yeah, it's just more to see if their expectations link up with the plan I have for them. Also with the subjective, this is off the back of coming out of lockdown. My subjective form, I send to them before the session.
Okay.
So it's good and bad. It allows me to go into the first session with a clearer picture and a plan. But I do miss that, the contact and building up the rapport. So I think your first question was, how long do you spend on the subjective? I usually spend another 10, 15 minutes at the start of the session just chatting to them. So I'm mobile, so either while I'm setting up or just while I'm getting the stuff ready, and just try and get more information out if I have more questions or if they haven't sort of elaborated on the form.
Yeah. Does anybody else still do like send out the subjective, not like the screening stuff? Does anybody else still do that?
Yeah, I do, but mine's through SIF. So it's like the questions come with when they've booked it, it'll get sent straight to them as the questions that they have to answer before I see them. So it does help, as you said earlier, it's useful to get the information beforehand, but sometimes then I can elaborate on the questions that they've answered to find out a bit more information on what they've asked, just because it then gives you maybe more questions that you can lead on earlier on into the appointment than you would have done originally.
Yeah, it's interesting. It's like, obviously it clearly works for you guys. It didn't work for me at all. I really struggled with it. So I stopped it. I really struggled with doing like virtual appointments and stuff because I missed the actual interaction with people, the actual physical interaction with people. And I just didn't feel like I could work as efficiently that way. Also, I just found that people, well, I forgot to fill it in. And
Yeah,
then you just have to do it anyway.
Yeah, I was gonna say during the kind of higher COVID periods, I definitely did more pre-consultation pieces just over the phone, if it was, especially if it was a new client, or if there was something more complex going on. So I was obviously minimising that contact time, which is obviously what we will do more of, but and it's my preference. But did switch a little bit during lockdown for that.
Yeah, I found myself going in with preconceived ideas. If I read the form previous, I found myself going in with like, all right, it's this, and then they come in and be completely different, and I'd be like, so it didn't personally work for me. So I went back to sitting down next to somebody and chat to them. But it's whatever works best for, you know, and that's what I said throughout all this. It's what works best for you, what adds value for you. It's not. And that's what, once again, at the beginning, I want this to be a discussion rather than a lecture, you know, kind of bringing up things that which may help people along the way, and kind of it provides a bit of structure. But that's kind of, you know, there's some stuff in there which I don't use, you know, but somebody who is in this room right now, or somebody who listens back to this, may use it because that might be useful for them. So I want to try and make it as widespread as possible, but just, you know, don't rest on my own laurels and my own biases. So yeah, it's what works best for each of you and within your practice, really.
There's
Anything
just
else?
another one from there for me, Scott, is
Go
that
ahead.
when people go into assessments, whether that's a client or the therapist going into it, especially in that first sort of session, there's nothing there in the rule book that says there has to be any form of hands-on treatment. It is that common misconception, because they're paying this, they're expecting that, and this is where the expectations need to be set, saying, look, this first session may not have any sort of treatment. However, this is for me to get to know you and you to get to know me, and that, you know, and that's where and that's what a lot of people miss. They go to the GPs, they go to NHS physios, they all have their place, but they're not able to open up and have that conversation. So that for me, there's nothing there that says you have to have hands-on physical treatment either.
No, not at all. You know, it's once again, if one of the best sessions I have ever had was an initial consultation, and it was probably an hour and 20 minutes just sat talking to somebody and just kind of reassuring this person she was not going to keel over, basically, because you know, she was convinced that she was going to be in a wheelchair, you know, because her mother ended up in a wheelchair and she had all these other things, and you know, she's been passed from pillar to post in the NHS, and it was just me going, no. You know, we went through all the screening, went through some movement stuff, we went through, like, no. She was like, no, I can't do this. And then I got to, you know, I used this, so the scale thing, but she was like, no, I'm not strong enough, my back's not strong. And I was like, right, we'll do some, you know, general strength stuff. Let's see what, I can't. And then literally just put her on that and go to pull on that and go, right, that's how much you can lift without pain. You know, and it's kind of just gives that person, oh God. And she went up, I didn't touch, you know, apart from like a little bit of active movement stuff. There was no hands-on treatments. But what I gave her was like massive confidence.
It's the confidence. And this is what I was saying. It's that sometimes it's that conversation, and then it's easier for the later sessions. If you are hands-on, they've got that bit more faith in you as well. You know, so yeah, for me, conversation is massive.
Yeah. Cool. Anybody else got anything they want to add in? Any thoughts on the stuff we like discussed? Anything?
I think for me it was good just to reflect on actually what you do. That was what it was always going through my head, just to kind of see you know, different kind of components, and actually think about what I've been doing, how I've been doing it. A few little reminders as well to go, oh, actually maybe I should be doing more of that. But
to be fair, I got that when I was writing it as well, going, oh yeah, I haven't done that bit in a while, maybe I should.
Yeah, but I'll have to go now as well. But as you see, I'm now sitting in the dark. But okay.
I know it has got very dark where you are.
Yeah.
So,
but no,
guys,
been great to join you all.
Thank you very much for joining. I don't know when the next, so these are not coffee chats anymore. These are kind of like, I just called them clinic chats. I didn't know what else to call it, to be honest. So the coffee chats, as they were, they're now open to the wider industry, and they're going to be once a month. So for like the business type stuff and, you know, general support, me and Gary are still going to be running those once a month. These ones are more aimed at kind of clinical reasoning and kind of getting people's brains ticking with regards to that kind of stuff. So it's like just another free CPD thing that we're going to be doing. So like I said, they're going to be recorded. So if you don't join in, you know, you can catch up at any time. Or if anybody's got anything they want to discuss afterwards, you know, feel free to just drop me a message. Okay. Thank you very much, you guys, for joining in. Enjoy what little left of the evening, and hope to speak to you again soon.
Thank
Cheers,
you.
Scott.
Cheers, guys. Bye.